Hi, this is Dr. Bernstein with our March 2018 teleseminar. Before we start today, I want to remind you that the answers I give to questions are generalized answers that may not really apply to the person who asked the question. The importance of these questions is for the general listenership. I cannot possibly examine, get a complete history, complete family history, etc., for every person who asks a question. So the answer I give may not really be applicable, but it should be of interesting general information. We have a special subject today relating to an article in a recent issue of the New York Times. The title of the article is "Diabetes Care Can Be Costly Yet Wasteful." And the author of this article claims that for type 2 diabetes, measurement of blood sugar, which Medicare will pay for 3 strips a day, is a waste of money and may be harmful in some way. And the reason they have this article is because there was a report in one of the diabetes journals to the effect that for type 2 diabetics, number one, measuring blood sugar doesn't seem to make a difference in their hemoglobin A1C. And number two, even though Medicare may pay them to buy strips, most of the type 2 diabetics don't use the strips anyway. In fact, many type 2 diabetics are actually selling the strips that Medicare pays for, selling them to type 1 diabetics or to brokers who in turn sell the strips to type 1 diabetics. Now, if that's what's happening, then the strips are being wasted. Well, you can't say giving them to type 1 diabetics is a waste, but the Medicare money is not going to accomplish anything for the Medicare recipients. However, the big problem with type 2 diabetics and blood sugar test strips is that most physicians do not know how to utilize the information from the blood sugar tests. Furthermore, 3 strips a day for a type 2 diabetic are not adequate at the time that you start to treat them. If I'm treating a type 2 diabetic, I need something of the order of 10 blood sugars a day before I can work out their diet, their medications, and so on. By the end, on so on, I mean not just what medications, but the amounts of the medications and the timing of the medications. Timing can be very important. So once I've started a new type 2 patient, on a new regimen, new diet, I have to see, I might be looking first at just the effects of diet. So I need blood sugars before and for 1 and 2 hours after each meal. If I'm giving medication, I may need blood sugars during the night. I need, as I said, at least 10 blood sugars a day in a new type 2 patient. Eventually, if I get them stabilized on the right diet and the right meds, and they adhere to this, I may only need 1 day's worth of blood sugar a week. I might need for that day only 5 blood sugars or 6 blood sugars. But to blanketly say that 3 blood sugars a day is paid for by Medicare is a waste of money and is potentially harmful is correct for most diabetics, but not for the diabetics who are trying to keep their blood sugars normal and are using my book as a guide. They are going to need a lot of strips every day while they're working out their initial regimen. Now we'll get down to the questions. Can you explain Lada? That's latent autoimmune diabetes. And what type of diet one should follow to gain weight? I use small doses of basal insulin and increased my carbs to 45 grams per meal due to weight loss. Well, first of all, I've explained Lada in the past, and Lada is a disease that has variable effects depending on the individual and the genetics of the individual. People with Lada frequently require insulin injections. Sometimes they're insulin resistant and require large doses. Sometimes they need very small doses. So there are various types of Lada. And the type of Lada you have has nothing to do with the diet. The diet should be as low in carb as possible, just as described in my book, Diabetes Solution. And to gain weight, you don't increase the carbs. You don't increase the carbs and increase the insulin. If you want to gain weight, you increase the protein and increase the insulin. Increasing the carbs increases the variability of the results. Carbs have a much greater effect on blood sugar than does protein. So we recommend increasing protein and increasing insulin in order to gain weight. Since the FDA has approved Freestyle Libre 14 blood sugar monitoring system, I am getting many ads everywhere. I'm getting many ads everywhere I look. I do worry that the insurance industry will push me to use this over the Dexcom. Well, the problem with the Freestyle Libre, which we've described in the past, is that it will not give you an alarm if your blood sugar is too low. The Dexcom also gives you an alarm when it's too high, but in the case of patients who follow my book, we don't expect to see dangerously high blood sugars. We use the Dexcom mainly to catch hypoglycemic events. So it could well be that if the Freestyle Libre is less expensive than the Dexcom, that insurance might push it, and that would be dangerous because you're depriving patients of an alarm system, which you do get with the Dexcom. I have my alarm. You can choose the sound that your alarm rings. Mine is a fire bell. Update on FIASP. Any advantage for corrections using a small dose? Now, FIASP, as most of you probably do not know, is identical to Novolog, except it contains an addition of L-arginine, which is a precursor of nitric oxide, which is a natural vasodilator that the body makes to dilate blood vessels. So if you've got a vasodilator mixed in with the Novolog, the blood vessels near the injection site are going to be dilated and more likely to absorb the insulin rapidly. So FIASP claims that they're faster even than Humalog, which is up to this point the fastest insulin we have. I've not tried FIASP, and when talking about small doses, as for children or very small corrections, we should be thinking about the possibility of diluting FIASP. And it would be very nice if we could, and we don't know it. Um, I've contacted the Novo people. They have no idea. They've never thought of diluting it and cannot recommend diluting it. If any of my listeners are interested in trying to dilute it, you could give it a try with the same diluting fluid that is used for Novolog, and let's see what happens. Um, you could get back to us and let us know what your experience is. What I'm wondering is, will it retain full potency? Will it still work as fast? And of course, I want to know, does it really work faster than Humalog? I haven't tried it myself. I should be trying it, but I've been too busy. Recommended an angiotensin receptor blocker for mild hypertension. Now that valsartan has been reduced, someone wants me to recommend an angiotensin receptor blocker other than valsartan, which supposedly has been recalled. I don't know. I didn't even know that valsartan had been recalled. I don't like to start patients on an angiotensin receptor blocker. I prefer ACE inhibitors. The only disadvantage to an ACE inhibitor, which has less adverse effects than the ARBs, uh, is that the ACE inhibitors cause a cough in some people. The cough is not a fatal cough, and it goes away if you stop the ACE inhibitor. So I would much rather start someone with an ACE inhibitor and only use the angiotensin receptor blocker, or ARB, if the ACE inhibitor causes a cough or other side effects. Test strip update. Contour included with Dexcom, reliable in the normal range, question mark. There are continually, or I shouldn't say continually, maybe once or twice a year, some group or company will want to test blood sugar test strips. And the top two test strips usually, but not always, are the Contour One Next. That's the name of the product, Contour One Next, and the Freestyle Freedom Light. In my experience, in the vicinity of normal blood sugars, say blood sugars around 80 to 100, we get best results with the Freestyle Freedom or Freedom Light. The Contour comes in next. And that's my experience so far. I haven't read most of the studies that get published show you the rankings based upon all blood sugars studied. I'm not interested in accuracy at blood sugars of 200 or 300 or 400. Sometimes you'll find the Contour reading above the Freestyle because it's maybe more accurate at a higher blood sugar. But my experience goes only at the normal blood sugars or thereabouts. Type 1 diabetic son, diagnosed in September 2018. My biggest challenge has been the nurses at school. Just today he was at 86 and she gave him juice. This is not in the doctor's orders or the 504 plan. I don't even know what the 504 plan is. Do you have any recommendations on how to direct the school nurse? I am still so new at this, but even I know that juice is not needed when he's at 86. Well, I could make the following suggestions. First of all, give the nurse precise written instructions. Uh, Secondly, speak to the nurse and see how cooperative she wants to be. If she wants to be cooperative, she'll follow your instructions. She'll even phone you on your cell phone if she has a question. On the other hand, I've had stories uh, from parents of kids whose school nurse wants to follow ADA guidelines, and these guidelines are geared toward very high blood sugars. And if that's the case, that the nurse does not want to be cooperative, you have to speak to the principal of the school and try to get him to uh, encourage her to be cooperative. If this principal doesn't want to be cooperative, then you'd probably be wise to hire an attorney, because diabetic children fall into a class of disabilities that require special medical dispensation in schools. And it may be necessary for the attorney to remind the principal of what the laws are in your particular state. We've been told low carb can stunt growth. Our son is 2, and the current doctors want him to eat a chunk of carbs at each meal and up to 15 undosed carbs between meals. Is this accurate thinking? Well, first of all, when you talk about undosed carbs, you're probably thinking about the old regimen that I was brought up on, where I got a shot of long-acting insulin once a day, and I had to eat all day long to cover the insulin. This is an ancient philosophy. The ADA may recommend it for some patients, but even the ADA has begun to think about basal bolus dosing, as we advocate in my book. Certainly, what the doctors are telling you are incorrect. And when you talk about growth, I remember back in the 1980s when Bill Tamberlane at Yale published studies showing that type 1 diabetics would initially go off their growth curve. There are Iowa State growth curves that are used around the country now, and each kid has his own curve. And when they became diabetic, their growth and usually their weight went below their prior curve. And then when he normalized blood sugars, they went back to the curve. What are the most important things to do to control blood sugar for a newly diagnosed child with type 1 diabetes? It's not a matter of most important things. There's a whole slew of things, and they all have to be done. You can't just pick certain things. The first thing, in a sense, is diet, because you'll never get the insulin doses right if you're on a high carbohydrate diet. But you have to follow the detailed guidelines that are set forth in my book, Diabetes Solution. It's not one thing at a time. I'm a busy mom of 2 little kids at home. Can I do your dietary suggestions without considerable time? Well, again, read my book. Although there are recipes in the book, you don't have to be a cook. There are many ready-made foods that you can make. After my wife died and we didn't have a housekeeper, I made my own meals. I'm not a cook. The best I can do is scramble eggs, and I would get ready-made foods like cheeses, smoked salmon, certain selected low carbohydrate nuts, etc., avocados. So you can really get by with no significant amount of work. And now that we have electric refrigerators, which we didn't have when I was a kid, you can buy things in the supermarket and stow them so you can go shopping maybe once a month for the food that you need. What do you think about the closed loop products out there today? Not so much for the mealtime boluses, since those are minimal with Dr. Bernstein's diet, but for basal rate. Well, the closed loop devices are devices that are measuring your blood sugar and telling an insulin pump how much insulin to give to you. So this is a very reasonable question. Because we have to, type 1 diabetics have to worry about the dawn phenomenon, where for a few hours in the early morning you need more insulin. The pump, in theory, could take care of that for you. You could have a constant basal rate, but for a few hours before you get up in the morning and after you're up in the morning, increase the basal rate. And that, in theory, works. But in practice, there are problems. You have a foreign body under the skin injecting the insulin that's there all the time, causing inflammation initially, and that inflammation can lead to unpredictable absorption of insulin, but eventually you get scar tissue at these infusion sites, and the scar tissue inhibits the absorption and makes it even more unpredictable. On top of that, when you're talking closed loop, you have a system that is supposedly measuring your blood sugar and dosing out insulin in response to your blood sugar. The trouble is that the sensor is not really measuring blood sugar. It's measuring interstitial glucose levels, the glucose level in tissue fluid between the cells in the subcutaneous tissue. And that tends to run about a half an hour behind blood sugar. So right away, your data is out of phase to the extent of a half an hour. And the algorithms that are fed into these devices for adjusting to blood sugar are not necessarily going to work for the same for each individual, in part because the absorption of insulin is going to be different for each individual, depending upon the infusion site and so on. So I would not recommend these devices for this purpose. What we do to circumvent the dawn phenomenon is use the longest acting insulin we can find. We give it on a rising and at bedtime. And for some people, full type 1s who are not making any insulin, they may have to get their second basal dose instead of on a rising in the morning, several hours before they arise. So we actually do have people waking up a few hours early in order to get a shot. With kids, the parent can do it. Another thing that we may be doing is giving a rapid acting insulin on a rising to prevent a blood sugar increase after you get up. I just today spoke to parents of two children who are getting diluted Humalog insulin on a rising to prevent a blood sugar rise. would like to know more about proper timing of NPH for basal coverage in a 3-shot regimen. The morning NPH coverage starts to fade about 12 hours after the shot. Not able to afford Levemir at present time. So this is a person who's trying to make NPH, which is an intermediate acting insulin that in this day and age has no function, this person's trying to make it work as a basal insulin. And the only way to make it work as a basal insulin would be to take it several times a day, because it tends to wear off after about 8 hours. This person says 12 hours, but I would think that he would have to take it at least every 8 hours. And I would start by trying out a third of his current total dose of NPH every 8 hours and see what happens. He may find that the last dose, which is the one prior to getting up in the morning, has to be a little higher than the other doses in order to take care of the dawn phenomenon. That's about all I could think of. You could give it a try. By the way, if you can't afford Levemir, you probably can't afford Tresiba. In your country, they may be at the same price. It all depends upon the insurance company. If you don't have insurance, of course, they both may be unaffordable. Some insurance companies will give you Tresiba for free, some will give you Levemir for free, some will have a copay. They're all different. What is the best resistance starch that passes through to the large intestines without being digested or raising blood sugar? How does resistant starch affect blood sugar? To my knowledge, there's no such thing as a starch that does not raise blood sugar. There are starches that raise blood sugar more or less than others. For example, there's the two most common starches are amylose and amylopectin. Amylose is straight chains of glucose molecules, and these chains can, in a product, be lying flat one on top of another so that the digestive enzymes that would ordinarily rapidly convert the amylose to glucose have trouble getting in between the chains. Amylopectin has branches, so it's like a tree with branches sticking out, and these branches prevent the underlying chains from occluding one another. So you get empty spaces between the branches, which allows the enzyme to creep in to more rapidly digest the product. So the difference is one of speed. The amylose will be digested slowly. The amylopectin will be digested more rapidly. If any company claims to have a resistant starch that will not affect your blood sugar, they're probably being deceptive. These starches will have some effect. Recent news investigative coverage indicates problems with insulin pumps. Have you any advice or do you have any guidelines respecting for whom those devices are a good choice? I cannot think of any human where there would be advantage to, well, possibly someone who's not going to be living very long. If someone has a life expectancy of a year, you might be able to get fairly good performance if you had a very low carbohydrate diet and did not use the bolusing algorithms that they give you, but rather the algorithms from my book. You might be able to do reasonably well with an insulin pump for such a person. It might take a year or more for them to develop scar tissue that interferes with the absorption. So if you don't expect to live much longer than a year, you might find some advantages, especially with regard to the dawn phenomenon, with regard to insulin pumps. If a youngster, 10 years of age, is newly diagnosed with type 1 diabetes, would it ever be possible to allow the beta cells to heal and the need for insulin to vanish? Well, not right now. Down the road, there are projects going on looking for ways to stimulate stem cells for new beta cells to replicate. There are several known stem cells for beta cells in the body. These include the alpha cells of the pancreas that make glucagon. They can also transform to beta cells that make insulin. They're the endothelial cells that line the ducts of the pancreas, through the ducts through which digestive enzymes flow. These can be induced to become beta cells, but there are some problems involved. Down the road, this may take place. But in the meanwhile, you should be giving your child normal blood sugars, which is much easier to achieve when they're first diagnosed because they're likely to be still making insulin. And the game plan is to, if possible, prevent their burnout. And there's a lot of evidence that high blood sugars are toxic to beta cells and will cause more rapid burnout of beta cells. I've had patients for over 20 years, over 30 years, still making insulin, even though they were type 1 diabetics, because we caught it very early and kept blood sugars normal. That's basically the best advice I could give. A few recent studies question the need to take insulin by people with diabetes. Do you still see any value in it? Well, actually, the American Diabetes Association advocates that all diabetics, instead of normal blood sugars, be given aspirin, a statin, and an ACE inhibitor. The aspirin is to prevent strokes. They now find that it's not very good at preventing heart attacks. The statin is supposedly to prevent heart attacks, and the ACE inhibitor to prevent kidney disease. My feeling is that if you're going to follow the ADA way and have elevated blood sugars, you're a sitting duck for all of these diseases and probably should be taking the aspirin, the statin, and the ACE inhibitor with whatever their side effects may be. On the other hand, if you have normal blood sugars, you could have tests done to determine whether you have early kidney disease or early heart disease or early cerebrovascular disease. And then your doctor can be guided by those test results. I had a coronary artery calcium score done a number of years ago, and that was after some 70 years with type 1 diabetes, and my calcium score was 1, which is very close to 0, which means absolutely no coronary artery disease. They found 1 plaque. So no way am I going to be taking, my creatinine clearance is normal, so my kidney function is normal. I did have some brain scans for cluster headaches, and there was no evidence of any problems suggesting potential strokes, so no way am I going to take any of these drugs. But it might be wise that long-term diabetics who have had elevated blood sugars be tested for all these things and maybe should receive these medications. So these medications can indeed be of value if you're at high risk. Endocrinologist had me tested and confirmed Lada versus type 2, LADA. I only use a basal insulin once a day, as well as Humalog as needed based on food eaten. Is there any benefit for me to continue to take Metformin? Good question. If you're overweight and need some help controlling appetite, or if the overweight is causing insulin resistance, there may be some value to Metformin. That's basically the story. I don't like the idea of taking Humalog as needed based on food eaten, because then you're guessing. You have no way of knowing how much Humalog to take, how far in advance of the meal, if you're changing what you eat every time you take a shot of Humalog. The guidelines that we have in our book don't even use Humalog for meals because it's too potent and works too fast. We use regular insulin. So I suspect that your blood sugars are not normal because of the way you're handling the eating. I noticed an overall increase in glucose readings. I stopped drinking alcohol about 3 months ago after experiencing a near-death experience with hypoglycemia. I noticed an overall increase in glucose readings since then and wondered if this is related to the cessation of drinking alcohol. Could well be. It's very possible, because alcohol paralyzes the liver so that it cannot perform gluconeogenesis, the conversion of protein to glucose. If a type 1 diabetic who's taking insulin takes insulin for a meal, it covers the protein and the carbohydrate in the meal. The protein can be used to build muscle, but the excess over and above what's needed for muscle building gets converted to glucose. And if you cannot convert it to glucose and you've taken the insulin for that protein, your blood sugar can drop too low. So if you're drinking a lot of alcohol, you're going to prevent this from happening. You're going to prevent the conversion of protein to glucose, and your blood sugar can drop too low. So that's the likely cause of your new problem. I am 38 and a maturity onset diabetic type 3. That's a monogenetic defect that affects mostly Eastern European Jews, and has its own interesting characteristics. My last A1C was improved down to 4.9%. I follow a low-carb diet, exercise, and take Januvia 500 milligrams once every 3 days. I'd like to put a bit more weight on. What would you recommend? Well, first of all, I'd recommend that you have your doctor read my book and that he increase the protein in your diet. You may not be getting enough. And then he probably would want to increase the amount of insulin you take to cover the protein based upon your blood sugars after meals. In your book, you have a diagram of insulin injection sites. Would it also be appropriate to inject into the fat pads on the bottom of the feet? Absolutely inappropriate for a variety of reasons. One reason would be that many diabetics after long years of poor control will have impaired circulation in their feet. And if you injure the feet by putting a needle into them, having impaired circulation may impair the healing. So you may actually cause infections. Another reason is that since you're standing on your feet, you're compressing the capillaries. Even if you have good circulation, you're compressing the capillaries, so impeding the absorption of the insulin into the capillaries. So you're going to get not only impaired absorption, but depending upon whether you're standing or sitting or walking, you'll get variable absorption or unpredictable absorption. So there's very good reasons not to inject into the bottom of your feet. Had an A1C of 9 to 10 until a few weeks back. That would be average blood sugars of about 300 milligrams per deciliter. Recently, I learned about you and your book. The first time in my diabetes life, it's been a few weeks that I have some control over my own blood sugar. I am running between 70 and 130. I have very low energy, palpitation when climbing the stairs, or get up quickly. I wonder why I'm now feeling this way. Did I change my diet too rapidly? There are several things that I think of. The most likely is that indeed you probably did change your diet too rapidly because when people have adapted to such high blood sugars, say around 300, if they get blood sugars that are much lower, let's say you go down to 180, you might get symptoms of hypoglycemia. And what you've described are some symptoms that could be those of hypoglycemia, even though your blood sugar isn't low. So people get used to higher blood sugars and feel hypoglycemic, even though their blood sugars are not physiologically low. And this is a warning that I give in my book. So if this person had read my book, he would have gotten that warning. When he mentioned palpitations when getting up quickly, that is not necessarily a sign of hypoglycemia, could be a sign of postural hypotension, could have low blood pressure or low blood pressure relative to the way it was before. It could be when your blood sugars were elevated, your blood pressure was also elevated, and now perhaps your blood pressure has also come down, and you have not yet adapted to the lower blood pressure. Do I have to inject some insulin before doing planks as exercise? I'd advise you to read my book. Some people, well, I really should recount what Elliot P. Jocelyn taught us some 75 years ago. I went to his classes up at the Jocelyn Clinic when I was a kid, and I can only remember one of the many things he taught. He said, don't run a block for a bus. If you're going to run for a bus, run a mile. And he pointed out that the stress hormones, epinephrine, cortisol, etc., would go up if you ran a short distance and would raise your blood sugar. Whereas if you ran a mile, you'd get enough exercise to bring it down. And it could be that the plank exercise, which is not a mobile exercise, you're lying in one position, it may require muscular strength to do this, but it may not be enough to overcome the stress hormones that you're making by doing this exercise. So it could well be that if you're going to do plank exercises, you should be taking some insulin. Or what you might do is do the plank exercise in between some more strenuous exercise. Do you suggest any supplements to help with glucose regulation? Offhand, I don't know of any supplements that can safely help blood sugar very significantly. There are some products like salicylate and berberine, which are not really supplements, that can have a small effect on blood sugar. There's one supplement, vanadyl sulfate, which is a compound of vanadium that has been found to have dramatic effects upon blood sugar, but it inhibits an essential enzyme, phosphatase, that takes part in many reactions throughout the body. And no studies have been performed to find the adverse effect of depriving the body of phosphatase. So although this vanadyl sulfate can have a significant effect, we don't know about the potential adverse effects. So I would suggest that if you need medications, you read my book, Diabetes Solution. Dr. Bernstein ranked the speed of 4 insulins in the last webcast, fastest to slowest: Lispro, Aspart, glulisine, and regular. It was very informative to learn about glulisine, but he didn't mention Fiasp. How does new Fiasp compare to the other 3 rapid-acting analogs? Well, I already spoke about it. It should be more rapid-acting. I doubt that it's more potent. How rapid-acting it is, we'll only find out by trial and error. I haven't tried it yet, so I can't really comment. The manufacturers claim that it's as fast or faster than Humalog, and this may be true, but I just don't know. For a type 1 who has followed the ADA diabetic meal plan, high carbs, for more than 10 plus years, could all future complications be prevented if none are present now by following a strict protocol of non-diabetic blood sugars? I have never met a diabetic of 10 years duration who was not loaded with many complications. The reasons that the patients usually don't know of these complications is that the doctors who have examined them have not examined them for the complications. There are such things as autonomic neuropathy, diplopia, and frozen shoulder, carpal tunnel syndrome, et cetera, et cetera. I probably test for at least 50 different complications of diabetes, and I usually find around 10 to 15 in a recent onset diabetic and over 20 in long-term diabetics like this 10 years here. So number one, you probably have many complications of diabetes. And if none were really present and you started having normal blood sugars, I wouldn't expect new complications to come. Furthermore, if you do have complications, I would expect the neurologic ones to reverse over time. So if you really have no complications, I wouldn't expect you to get new ones if you have normal blood sugars. During hospitalization related to gastric ulcer and gastroparesis, doctors wanted to keep my blood sugars above 100 and under 180. I told them this is criminal and represents a violation of persons with diabetes rights. Any advice? Well, you were lucky to get into that narrower range, 100 to 180, because many hospitals have much wider guidelines. And I've told the listeners many times in the past how I was hospitalized for minor surgery, and they would have had me in ketoacidosis many times over if I had allowed them to do what they wanted to do. I had to close the clamp on the IV glucose drip when my blood sugar was normal, and do many other things to offset what they were attempting to do. So I think that you were lucky that they were trying to keep you between 100 and 180. If you were there for only a few days, it wouldn't kill you, and you're lucky they didn't shoot for 300 or just give you large amounts of glucose without even measuring your blood sugar. My son is almost 3 years old. He just got diagnosed 3 months ago. Can you please give me advice on optimal blood sugar range for 3 years old? We are also slowly moving for a low carbohydrate diet and already see big improvements in his A1C. Well, first of all, I'd advise you to read my book, Diabetes Solution. I'd advise you to visit the website for Type 1 ONE GRIT, GRIT, and see what other parents of diabetic kids are doing. And slowly moving to a low-carb diet is sort of frustrating because you're going to have trouble getting normal blood sugars. And the amount of insulin that you need has to be will have to be changed in some sort of sporadic fashion, leading to unpredictability. The game plan should be to right away cut the both the carbohydrate and the insulin. And for a growing kid, even 3 years old, they are likely to require a lot of protein. Now, what's a good blood sugar for 3 years old? They probably should range around 65 to 75. Let's say target maybe of 70, but not at the beginning. At the beginning, you should shoot much higher because you're going to be making mistakes along the way, and you have the hazard of going too low. So you have to stick in a safety factor. You might want to shoot for 120 initially, and then as the blood sugars get better controlled due to your fine-tuning of diet and insulin, you can eventually shoot for somewhere around 70. I've had type 1 diabetes for 28 years. I'm 36 years old and presently have proliferative diabetic retinopathy in both eyes. My A1C is 6.5. With better control and lowering A1C, have you seen severe cases of eye disease been reversed in your patients? Yes, I have, but not after they've become blind or near blind. I've repeatedly seen normalization of macular edema, proliferative retinopathy, which is the production of small, fragile blood vessels throughout the retina. If you catch it in the early stages, before these blood vessels rupture and cause bleeding and hemorrhages and so on, then there's the possibility of preventing blindness, because then you could slowly reverse the proliferation, but it might take years. And if you have a hemorrhage in the meanwhile, sometimes the hemorrhages can resorb or be corrected with a vitrectomy. Trouble is, doing a vitrectomy on someone with these fragile vessels can be dangerous. So it all depends on the stage of the disease. Have you seen chronic kidney disease stage 3 reversed with a 6-12-12 carbohydrate, that's a low carbohydrate way of eating? Well, what is stage 3? There are at least two stage 3s. There's stage 3A, which is a glomerular filtration rate of 45 to 59. Normal is around 100 or so. Stage 4 is 15 to 29. I've seen people with stage 3A. With stage 3A, that stayed at stage 3A for many years. Now, this is surprising because once stage 3A means you've lost about half of your kidney function. So your kidneys are doing double duty. And the usual picture is that when they overwork, they can deteriorate. But I've seen stage 3A hold level. The glomerular filtration rate remain constant. So I think that jibes with the experience of people who have donated a kidney, where the donor of a kidney maintains his kidney function even though it's working twice as hard. I think the reason why diabetics with stage 3A are expected to deteriorate is because the blood sugars usually remain high and you're taking this already damaged kidney and damaging it some more. So I think that if uh, if you have half your kidney function, I think you could probably keep it by having normal blood sugars. Um, what's the rate of deterioration if you have more severe kidney disease? I don't know. Um, I've seen people with GFRs of 30 who held steady for a number of years also. So it could be that if you keep your blood sugars absolutely normal, you could have fairly significant kidney disease and hold the GFR steady. And as I said before, glomerular filtration rate is the uh, functioning capability of the kidneys. I've been pre-diabetic for about 4 years by ADA standards. I do not eat meat and have never eaten it. Could you advise how to put on weight and minimize blood sugar levels without meat and on a low-carb diet? Well, it seems pretty obvious. You increase any protein that other than meat. Now, I assume that you can eat fish, so you can eat fish, eggs, cheese, seafood. That's all I can think of offhand. Well, there are many cultures where you could eat insects. Um, uh, I used to have a pet turtle, so I don't encourage people to eat turtles. But I guess that's oh, wait, turtles you might consider meat. Um, anyway, those are my suggestions. Does low carb keep type 2 under control? I'm getting very worried. I don't want to go on meds. I assume that meds are medications. A lot of people are afraid of medications, but elevated blood sugars over the long pull can be a lot more harmful than many medications. I would look at blood sugars. I'd look at blood sugars before and after meals and several hours after meals. The game plan should be to keep blood sugars normal around the clock. For an adult, probably around 83 all day long before, during, and after meals. And if you can do that with just diet, great. If your doctor thinks that you need medication to get your blood sugars down into the normal range, that would be a good idea. But that would be in addition to the diet. I am type 1 diabetic for 31 years with an A1C of 4.9, thanks to your advice. I am also taking metformin, which I thought was suppressing gluconeogenesis, and it seems to be, except when I exercise. First of all, metformin does not, to my knowledge, suppress gluconeogenesis. It does inhibit the absorption of carbohydrate and seems to have most of its effect on certain enzyme systems in the gut. I thought that metformin would be like a prophylactic against blood sugar rise. What do you think is going on here? So this person says he exercises submaximally on a stationary bike for 35 minutes. The key is submaximally. Again, my old message about what Elliot Jocelyn said. If you're exercising and you're exercising too mildly, you can raise your blood sugar if you're a diabetic. So the thing to do is exercise more strenuously. Now, you may have a heart condition and can't get away with doing that. I can't comment on that. You'd have to see your doctor about it or see a cardiologist. In fact, before I will prescribe uh, intensive exercise for any of my patients over the age of 40, I require that they get a coronary artery calcium score, unless they already have known heart disease. But I want to rule out any form of heart disease before I push them to exercise. And the kind of exercise I do, aside from muscle building exercise, is heart rate exercise, where I get my heart rate at or above my theoretical maximum. So right now, when I exercise, I get my heart rate up to 158 to 160. And I don't do it for a long time, but it's high enough to bring my blood sugar down, not to bring it up. Another thing that you can do if it's hazardous to do intensive exercise is to take propranolol before you exercise. That keeps your heart rate down, but it also stops you from making adrenaline that may raise your blood sugar. We have a lot of kids whose blood sugars go up when they exercise, especially when they do competitive exercise. So it might be from the anxiety of playing a team from an out-of-town school. Their blood sugars go up. We give them propranolol, and their blood sugars don't go up. For the kids, we use a very small dose, about 5 milligrams. Thanks for listening tonight. Our next teleseminar will be on Wednesday, April 24th, 2019. Look forward to seeing you then.